Thank you. All right. Well, I got to do this thing too. Howdy! Howdy! I'm learning, okay? Didn't graduate from A&M, but I got here as fast as I could. All right, okay. We are going to be focusing on women's health issues today, and I think most of y'all know who I am, and this is part of Living Well Aware, and actually this seminar is part of Living Well Aware at Texas A&M. And when we're in the second year in this, and it's been wonderful for the last 2 years being involved in the wellness of Texas A&M employees. So this is just part of that. Thank HR for that. Before we begin, thank you for attending. This is awesome. You're investing in your personal wellness and that of maybe your family members, friends, and those you know, because you're going to learn a lot of information today, and I'm going to make it well worth your time. Now, we have until about 1:30. Is that okay? And I know if some of y'all have to leave and walk out early, go ahead, and I hope you're not leaving in disgust. But at 1:30, I know this women's health is so broad, and you may have a personal question or whatever. I'm in no hurry to leave. So I'll stick around and go over in the corner, and y'all can come one at a time or whatever if it's personal, and I don't mind you're sharing your story and me being able to direct you in a certain fashion. First of all, is there anyone here that has never heard me speak? So a few people. Well, where have you been? Well, thank you. Thank you. Raise your hands again. How many have never heard me speak? So we got a handful. Well, thank you. I'm glad that you're here. Glad you're here. All right. And I am excited to be here. First of all, I'm professionally involved in women's health issues. I am a gynecologist. All right. I've graduated from medical school in 1980 and finished my residency in obstetrics and gynecology in 1985. And I was in the military. Did my training at Walter Reed Army Medical Center, and then came to Central Texas. I got back to Texas as fast as I could, and I was at Darnell Army Hospital in Fort Hood, and then 31 years ago, left there and came to Scott & White, and I've been practicing OB/GYN doc at Scott & White in Temple, Texas ever since then. So I know a little bit about what I'm talking about today, all right? And also, I'm a patient. The issues I'm going to be talking to you about, I'm personally involved in. Either I've been through them, I'm going through them, or they're in the future. All right, so I'm personally invested in this, okay? And I'm committed to improving my health and happiness and those of my patients and everyone that I encounter, okay? And so once again, I'm really excited that I had the opportunity. When Mary said, because I've come here and I've had a 2-hour seminar on sleep, which I'm totally vested in also. That important aspect of our life, which mine used to be really bad. Now it's so much better because I invested time in it. I was asked to come and speak on how to develop a mission statement and all. So when Mary Schubert said, would you mind speaking on women's health issues? Really? Something I don't have to prepare for? That was great. It was great. So the goal of today's seminar is I'm going to give you some up-to-date guidelines and recommendations on some of the more common women's health disorders. And I'm going to help you be an educated consumer of the healthcare industry, all right? Because there's a lot out there that's being offered to you. I'm going to hopefully clarify the confusion in some areas, but this seminar is not about providing specific medical advice, individual medical advice. I think you're going to get a lot of information that's going to help you and direct your care, though. But I am not your doctor, okay? Well, a few of you, I am your doctor, okay? Well, general guidelines for screening tests and treatments apply to the majority. They don't apply to everyone. Some of you don't need as much screening, and some of you are going to need a lot more because of your family history and your medical conditions. So keep that in mind. So here's some of the topics we're going to cover in about the next couple of hours: exams and screening tests, menstrual disorders in adolescents and reproductive age women, perimenopause, menopause, hormone therapy, diseases of aging, which we are all doing. We're all aging, right? And we're going to talk about some of the more common ones that really lead to disability and death, if we don't manage them earlier than we would want. And I'm going to touch on supplements. Of course, that's a topic I could speak 2 hours on by itself, and maybe I can come back in the future doing that. I'm actually going to be doing that next month in Montana for the University of Montana. They've got Jeff and I, my husband, Dr. Jeff Waxman, is next door. He's the urologist. I'm the gynecologist. We have this part of the body covered, but we're going to cover a lot of the other parts today also. But next month we actually go to the University of Montana and put on a 1 day, a 7-hour, 6.5, 7-hour seminar. One of the topics they've asked us to cover is supplements. So we'll hit on that a little bit today. Okay? So first of all, how often should you go for a checkup? Right? Now some people would say every year. And that's what us ladies are used to, right? You need to go see you have a female pelvic exam every year, all right? And so, and that's really controversial. If you've had, bless you, if you've had normal exams, you have no female problems, and as we'll talk about, pap smears are being spaced out, that's really not mandatory. And the U.S. Preventive Task Force says there's no data showing that that's really gonna help you live longer. What? Can I talk louder? Okay. Okay, I will talk louder. And if you ladies, if my voice goes down, just raise your hand and just say, hey, get louder. All right, I don't mind at all. Just remind me. Is this okay? Okay, great. So I'll try to talk louder. Okay. So just have that in mind. So if you're late on your annual pelvic exam, don't be freaking out. All right. Now, if you've got female problems, for sure you need to be going in. But I'm not so concerned, and this is coming from a gynecologist. I'm more concerned that you're going to your primary care doc and getting your internal medicine physician, your family medicine physician, your general practice PA, nurse practitioner, or whatever. I'm more concerned that you see them. All right? Because as we're going to talk about, we really don't die of female issues. That's not at the top of the list. It's all the other stuff. So if you're really, really healthy, everybody needs to go in for that general exam, find out what problems do you have, and then if you have problems, you may be going every 3 months to manage your high blood pressure, diabetes, or whatever. But everybody needs to get in there, and if you haven't been in a few years, definitely get in there, get that checkup, and get updated on all the stuff we're going to talk about. All right? And there are people like my husband who is next door. Every year he goes to see his internist. Every year. And he's bugging me about going when I'm late to see mine. Yeah, but he goes every year. Although he has a perfectly normal blood pressure, his cholesterol is to die for. It is amazing. Yeah, but he goes every year. He goes, I don't care, I'm going to go every year. You know, and there's nothing wrong with that. I think it probably is overkill. But I would rather him do that than me have to bug him, honey, it's been 5 years, okay? So, and once again, I don't know if y'all have any paper or anything or write on your lunchbox questions, because intermittently throughout this, we're going to stop occasionally, take a few questions, and I'm going to allow for questions at the end, okay? All right. Okay, so what about recommended screening tests? Well, actually, they're based on common causes of death. We can't screen for everything, right? It would cost trillions of dollars every year, and you'd be having CAT scans every year and everything. We can't screen for everything. We have to base it on the common causes of death and disability. So remember, what do we die of? Heart disease, cancer, chronic lung disease, accidents, and stroke. Okay, there's really no screening test for accidents. We just ought to be careful and throw the cell phone in the back seat of your car, all right? But if you look, heart disease and stroke, number 1 and number 5, add them together, that's cardiovascular disease, the #1 killer of men and women. So a lot of our screening tests are cardiovascular. Now, if you add heart disease and stroke together, cardiovascular disease, behind that it would be cancer. So that's why a lot of our screening tests are going to be based on these big killers of death, the top killers of death. And that's why I always say, essential element number 1 is normal numbers now. No matter what else we talk about, urinary incontinence, hot flashes and all, you know, you're going to be able to have those hot flashes longer if you're living longer, okay? All right, or we can get rid of them longer, hopefully. You have got to remember that if we don't get these numbers in order, it's just killing us. Thousands of people are going to die this week in the United States, thousands needlessly because they ignored these numbers. All right, so I'm going to talk about a lot of other things today, hot flashes and heavy periods and everything, but don't forget what's at the top of the list of what we need to do. Have these numbers. Other tests like having an EKG, electrocardiogram, a stress test, chest x-rays and all, that depends upon your age and your family history. And what's your high blood pressure, if you have high blood pressure, diabetes and stuff. All of a sudden you may be getting additional tests. But other tests are normally not recommended for most of us. I don't get an EKG and I don't get a chest x-ray or a stress test, and I'm going to be 66 years old. So, because I don't need those because I'm at low risk. Some people younger will, but don't downplay that. And remember the American Heart Association's 7 health metrics. All right? And if we meet these, they dramatically decrease our risk of death and disability, and that's what wellness is all about, okay? And remember, if you go to my website, livingwellaware.com, click on the Publications tab, there's the Partner with Your Provider handout, which has all of the normal numbers on it. What's a normal cholesterol, BMI, and everything, then you plug in your numbers. You can print that out, okay? It's all on there. So what are some of the recommended screening tests for cancer prevention? We've talked about, you know, like heart disease and strokes. We've got to get those tests done. The cholesterol, blood pressure, weight, fasting blood sugar, things like that. But what are some of the screening tests now for cancer prevention and early detection? Because right behind cardiovascular disease is all the cancers added together. And you know, what are the most common cancers we see in the United States? Well, next door, they're going to be talking about prostate cancer and lung and the bronchi, colorectal and stuff. But some of these are very similar. But for guys, it's prostate as far as number of estimated new cases. For women, it's breast, followed by lung and colorectal. Uterine cancer, this is uterine corpus. That's the upper part of the uterus. That's not cancer of the cervix. Okay, cancer of the cervix is caused by HPV, human papillomavirus. And now that we're vaccinating millions of adolescents and young adults, we're going to see cancer of the cervix plummet. It already doesn't even make the list. It's way down there. It's way down there. And it's because of pap smear screening, which we'll talk about, and now the HPV vaccine. All right? But this is cancer of the body of the uterus, the upper part of the uterus above the cervix. And we're going to talk about why it is increasing in the United States. So what about estimated deaths? That's incidence. This is, yes, a heck of a lot of women get breast cancer. A lot of men get prostate cancer, but that's not the top cancer death in either group. For men, it's lung cancer, and so is it for women. Lung cancer is the #1 cancer killer of women and men. So we don't want to smoke. And we don't want to be around people who smoke. All right, secondhand smoke. And we want to watch the air we breathe. All right, I'm glad we live here in Texas and not Los Angeles. All right, okay. Now, breast is the second most common cause of cancer death in women. But we are doing a wonderful job. There'll be, 250,000, close to 300,000 women diagnosed with breast cancer this year. But the cure rate is like over 90%. Yeah, it says that those few women that succumb have those really bad tumors, which fortunately are the minority, not the majority. Our treatments for breast cancer have so much improved. And I think it's been the treatments that have really propelled survival, maybe more so even than the screening. That's people go both ways on that. So what about prevention or early detection of cancer? If we look in women, we're talking specifically in women, pap smears and mammograms. So how often should we get a pap smear? Remember, a pap smear is a screening test for cancer of the cervix only. It does not test for cancer of the ovary, doesn't test for cancer of the uterus, the uterine corpus, that part of the uterus above the cervix. It doesn't test for that. It doesn't test for cancer of the vagina. It only tests for cancer of the cervix. All right? And the majority of women who get cancer of the cervix are in their 30s, 40s, 50s. But we now know it's caused by HPV. And when did you get the HPV? Adolescence and your young adult years. Right? That's when you get it. But by the time you get the HPV, it literally takes years and years and years and years before you develop cancer. Teenagers do not get cancer of the cervix. Although there's a lot of kids out there with, girls out there with HPV in their vaginas and on their cervix. I've never seen cancer of the cervix in a teenager. Actually, in anyone under 21. That's why we do not start Pap smears until the age of 21. We now know, just don't do Paps, we're wasting time. And we'll pick up these mild abnormalities, freak these girls out, do biopsies and all these tests, and the only people it's benefiting are gynecologists who are driving really nice cars. It's not benefiting the teenager at all. So now, I said Pap smear. Did I say pelvic exam? Do not confuse the pelvic exam with the Pap smear. These teenagers, I do a pelvic exam on them. They're sexually active. They've got STDs. They may have genital warts I need to treat. And I need to, if they're sexually active, I personally want to do, at least a mini pelvic exam because I want to know what's going on down there. And sometimes I just find it amazing what people do to their genital area. Really? I actually remember when women had pubic hair, by the way. Okay? All right. And I know a lot of people have tattoos, but really? Anyway, so don't confuse the pelvic exam with the Pap smear. Young people may come in and I may want to do an exam because I'm concerned about what's going on. But I'm not going to do the Pap smear, the test for cancer of the cervix, until they hit 21. In Europe, they don't do it until 24, 25, 26, because they realize cancer of the cervix under 25 is so rare, so rare. So we're really pretty aggressive in the United States by doing the Pap smear at 21. Now we know the Pap smears are so good we can space them out to every 3 years. So people may come see me every year, they want a pelvic exam. Okay, I'll do a pelvic exam. That doesn't mean I'm going to send the test for cancer of the cervix, the Pap smear, down to the lab. All right. That's about every 3 years we'll send that down because it's been shown once every 3 years is just as good as more frequent. Our Pap smears are better. Now, starting at the age of 30, and we're probably going to go down to 25, we're going to start doing HPV testing with the Pap smear. Because if you're HPV positive, particularly for what we call the bad types, HPV 16, 18, 31, 33, 35, and a few others, we know that even if your Pap smear says, oh, there's no cancer, no precancer, we know you're HPV positive. We are going to watch you closer. We're going to make you come back and we're going to look at your cervix with some high-powered lenses and filters and stuff and make sure everything's okay. So, and stay tuned, we actually may quit doing Pap smears in the future. We may only do HPV testing. The HPV test is actually better than the Pap smear. We really want to know if you're HPV positive or not. And I have a lot of my patients, some of whom I know very well now because I've taken care of them for years. They've become friends of mine. And I'm having to watch them closely because they're HPV positive, and I watch them every year. That once every 3 years doesn't apply to them. They're going to be watched closer. So how often you have a Pap smear is going to depend upon if you've had an abnormal Pap smear in the past and if you're HPV positive or not. All right. What about mammograms? All right. Anybody in here confused about how often you should get a mammogram? Sometimes it can be confusing because there really are 3 different recommendations out there. And I'm talking for general screening here. If you have a very strong family history of breast cancer, your mother, sister, grandmother had breast cancer particularly at a young age, before menopause, before the age of 50, this really doesn't, what I'm saying really doesn't apply to you. You're going to have to find out what kind of cancer that was. Was mom or sister BRCA 1 or 2 positive, i.e. they have one of the genetic problems, and do you? But this is for the general population, for the majority of us who do not have a family history. Because the majority, 75% of women who get breast cancer, they're the first one in their family. So a lot of women say, oh, that doesn't apply to me, that's not in my family. Well, guess what? Nobody in my family has ever had breast cancer either. And I have 3 sisters, 15 aunts, and grandmothers, and I'm still at risk for breast cancer. I could be the first one. So even if there's no family history like mine, I'm still going to go for screening, because I realize as long as I'm alive and I have breast, I'm at risk. Now, when should we start having mammograms? If you're the American Radiologic Society, and that's how they make their money, you start at around age 40. And you have them annually forever. Right? If you are the U.S. Preventive Task Force, which looks at all this data and comes up with guidelines, you really don't start till age 50 if you're average low risk. All right? And if you're the American Cancer Society, which I think they know what they're doing, the American Cancer Society, their job is to keep us alive, to lower our risk of cancer, or for us to pick it up early. They say start at around 45, around 45. So with my patients, between 40 and 45, I mention mammography and I give them the guidelines. And a lot of my patients are like, hey, nobody in my family has it, I'm waiting until like 45. And some of them are like, you know what, my best friend had breast cancer, I want a mammogram starting at age 40. Okay, okay. All right, so you kind of have to get your individual choice there, but know that there are 3 guidelines out there, and there are people that think we were maybe performing too many mammograms in young women who are at low risk. Most breast cancers are over the age of 45, 50. We're doing too many in younger women, and what happens, younger women have denser breast, and then you end up on the mammogram with a false positive. There's something that looks suspicious, but no, false, it's really not. It's what we call a false positive. And then you end up being called back, and now you're freaking out. Anybody ever been called back? Sherry, anybody ever been called back for a mammogram? Me too. I was called back. Go to have my mammogram, run back up to labor and delivery. They're calling me going, Dr. Sulak, we got this spot here, and we need to repeat we need to repeat some of the film, some of the x-rays. When would it be convenient? How about right now? And I'm glad it happened to me. I realized it's kind of freaky when you get called back, and and I'm walking over there, I was going, Patsy, get a life. Whatever it is, you're going to deal with it. Come on, life happens, and I'm going to have to deal with it. But that's what happens a lot when you do mammograms in younger women. It happens more so. It even happens to us older women when we have them. So just remember that. So let me stop there. Any questions about pap smears or mammograms? Yes, ma'am. What kind of test is the HPV test? It is a DNA test, all right? And it actually picks up the specific DNA for the HPV. It's not a culture. We cannot culture HPV. We have to go hunting for the DNA. And the DNA of HPV 16 looks different than the DNA of 18, and looks different than 6 and 11, which is HPV, that's benign. That causes warts, they're benign. And so we're looking for the high-risk types of HPV by looking for the DNA. And when we do the pap smear, we put the speculum in, we have a little brush and a little spatula. Those cells, we put it in the media, and in a liquid media, and screw the top on. We send it down to the lab. They spin it down, and they're running the test. They're looking for cancer, and in those cells, they're looking for cancer and precancer. That's the pap smear, and they're looking for the DNA. That's the HPV test. So they do both? They do both. If you're 30 and older, and probably starting at the age of 25, we're going to be doing both, I think, in the future. Right now, we're just doing the pap smears on younger women, because we realize a lot of them have HPV and we really don't want to know because they're probably going to get rid of it. By the way, 80 to 90% of people who get HPV, their body's going to clear the virus. They're going to clear it. It's the 10 to 20% of women who get HPV that don't clear it that the ones we have to follow closely. 80% of women in the United States will get HPV sometime in their lifetime. 80%. The only women that will never get HPV are women who've only had one sexual partner and that partner hasn't had any other partners. The odds of those women getting HPV, it's really rare to pick it up in any other way. Okay, good question. Thank you. Yes, ma'am.
For someone that has had a full hysterectomy, obviously they don't go for pap smears anymore. What do they go for?
Okay, very good question. She said for someone who's had a full hysterectomy, in other words, and by the way, a full hysterectomy doesn't mean that it has nothing to do with the ovaries. A full hysterectomy means the uterus, the body of the uterus and the cervix were taken out. That's a total hysterectomy. If the ovaries were left in or not, we have to add bilateral salpingo-oophorectomy, salpingo ovaries, oophorectomy, that's your ovaries. Tubes and salpingo meaning tubes. Now, if you've had your uterus removed and they took the cervix, which normally they do, but some women have a laparoscopic hysterectomy where they just go take the body of the uterus and they leave the cervix. And some women want their cervix left in because maybe it's going to give them more support to their vagina. And there's some people that say there may be a sexual benefit to that, although the data on that's not really good. But some women who have their hysterectomy laparoscopically will choose to have the cervix left in. And that's cool. I think that's great. And as long as your cervix is there, you follow the same guidelines. But if you're like most women who've had a hysterectomy, they took the cervix also, you don't need pap smears. Unless your hysterectomy was done for cervical cancer or bad cervical precancer, then you need a pap smear of the top of the vagina for a few years. But otherwise, the overwhelming majority of women who've had a hysterectomy, they've had their cervix removed with the uterus, the overwhelming majority have, you do not need a pap smear. And so her other question was, why are you going in? Good question. Yeah, a lot of women who've had hysterectomies, a lot of them have even had their ovaries removed. They continue to come see me every year. I go, why are you coming in? Because I just like to see you. Okay, why don't we go to lunch? Okay, let's go to lunch. It'd be a cheaper copay for you. You could take me out to lunch. Okay, right. Yeah, I'm cheap. Okay, yeah, but it's you would need to go in if you had any other problems. Say you had itching, burning, or whatever. Your ovaries are still in. Maybe you want to go in every few years just to make sure your ovaries are okay. Although I can tell you right now, the physical exam is horrible for picking up cancer of the ovary. Let's just talk about that right now. We have no good screening test for cancer of the ovary. All right. We are looking for one. I thought a couple of years ago they were studying one blood test, and I'm thinking, oh, this could be good. The data panned out not to be good. So we are still looking for a good screening test for cancer of the ovary. We don't have one. We don't have one. All right. So if you had your uterus removed with the cervix, you would go in for other reasons. Are you concerned about your fallen bladder? Are you having itching and burning? Loss of urine, incontinence that you want to go talk to your gynecologist. In other words, other problems. Very good question. In fact, that was an excellent question. Here you go. Where is it? I got one here, maybe. What size? This will work here. You get a t-shirt. There we go. There we go. Okay. All right. For men and women, colonoscopy. Because remember, if we look here, colon cancer in men and women. Yeah, it's a top 3 cause of cancer deaths, colon cancer. And the good news is, well, I'll show you later, it is coming down because now we have colon cancer recommendations. 20 years ago when I would tell my patients, hey, you need to get a colonoscopy after they turn 50, the majority of them had not had a colonoscopy or some form of cancer screening. Maybe some people don't want a colonoscopy and they're going to do a CAT scan with contrast, things like this. But colonoscopy is the gold standard, where you actually put a scope up there and look. It's no x-rays, you're looking inside to see if there's polyps or any evidence of cancer. And now the recommendations are for most people that we start at around age 50. But once again, it depends upon other factors, such as family history. I've got patients who are having colonoscopies in their 20s and 30s because they inherited the genetic risk factor for colon cancer. And they have all sorts of polyps and everything. I feel sorry for these people. They're going through colonoscopies early and they're at high risk for colon cancer. But for most of us, sometime after the age of 50, that we need to have it done. And now it's uncommon for a patient to come see me over the age 50 who has not had a colonoscopy, who's not had one. And that is fantastic. I can tell you, when I turned 50, I was right there at their doorstep. I've had an aunt die of colon cancer because she refused screening. There's colon polyps in my family. I was on the doorstep. And how often you have them done depends upon what the results are. If you're totally clean, no polyps, nothing, no family history, 10 years. You can go 10 years because the data shows the odds of your developing a problem during that 10-year time would be very uncommon. If you got polyps, family history, whatever, it could be every 5 years, every 3 years. All right? Like they found a polyp on my last one, so that they were concerned about. So 3 years later, they wanted me back. I'll be there. I'll be there. Because it's like one of my patients said, who kept putting it off and putting it off. Every year when she'd come back, and I'd go, have you had your colon cancer screening? Because I looked in the record, she hadn't. She goes, no, every year. And I go, when are you going to get this done? She goes, you know what? I'm going to get it done just so you'll get off my ass. Literally. She had colon cancer. She had colon cancer. Positive lymph nodes. They found the cancer, it was big, couldn't resect it through the, this is a true story, she doesn't mind me telling the story either. Couldn't resect it, they had to take out part of her colon, did the lymph nodes positive. Beautiful lady. I mean, she's like 5'10", dark hair, she was a runner, and just vibrant woman. And here she was running around races and everything, healthy as can be, with colon cancer. Fortunately, she did go in before it went to the liver and other places where it's difficult to treat. She went through chemotherapy, and this was like years ago. She's still disease-free. Disease-free. But I remember when she came back to tell me, she said, thank you. You saved my life. I said, no, you saved your life. You went and done it. You went and did it. And she goes, I always said colon cancer. She said, I always thought colonoscopy is inconvenient. She said, any of your patients who don't want it, tell them, what's inconvenient? Chemotherapy. And any of you who've had chemotherapy, you know what I'm talking about. Or have had to have major surgery, bowel resections. She said, and she handed me her cell phone number, and she said, you give them my cell phone number. I said, well, I'm not going to give them your cell phone number. But I said, I will tell your story. So one thing to remember, colon cancer screening is important. Question. You're not going to get another T-shirt.
No, that's
okay. And you're limited to 2 questions, so is it a good one? No. Go ahead.
You said the colonoscopy is like the golden.
Yeah.
There's a commercial on television that talks about sending in a stool sample.
Mm-hmm.
Is that?
Yes, she's talking about there's a commercial on TV about sending in a stool sample. We are looking for ways to actually take stool samples, look for the DNA of cancer cells, and come up with easier ways to diagnose. Right now, does it have the sensitivity and specificity of colonoscopy? I don't think so. Otherwise, I think we'd all be jumping on that other bandwagon. Yeah, I'll send in a sample, okay, rather than going through the bowel prep. But we don't have the sensitivity and specificity. But the good news is, for those people who just don't want the colonoscopy, there are alternatives. And by the way, it's so easy now. They give you a little medicine, you don't feel a thing. The prep's not bad now compared to when I did my first one 15 years ago. So much better now. Oh, much easier, okay? I'd rather have a colonoscopy than go to the dentist almost, okay? I mean, really. Okay. Lung imaging in smokers and ex-smokers. This is something that you ought to talk to your doctor about. If you are a big-time ex-smoker or you're a current smoker, there are recommendations now that you have a CT scan of the chest and all. So, and maybe a chest x-ray and other testing. So if you are a big-time ex-smoker, or you're a current smoker, or you know someone who is, talk to your healthcare provider about this. All right. Yes?
What about for secondhand smoke?
Secondhand stroke, we do not, I think I'm correct on this. There are not recommendations for having CT scans and chest x-rays, okay? But let me double check on that, okay? But I don't think so. I don't think so. Good question, okay? All right. Yes?
There are very few people that have this, but those that have a family history or a primary relative of colon cancer prior to 50, do they just back up the 5 years before that, or?
No, very good question. If you got that family history, how many years do you back up earlier from the 50? Really depends. There's some of these polypoid conditions, and I'm blanking out on the exact name right now, where literally you can get colon cancer in your really early, 20s, 30s, whatever. Your screening is going to begin a lot earlier. A lot of times for breast cancer, they say, if mom got breast cancer at 45, you need to start at 10 years, 35 before. But for colon cancer, it really depends upon what type colon cancer you're talking about. Okay, so it's not, they're not all the same. So some people, if you got the autosomal dominant genetic defect, you're at high risk for getting it, and you're going to start colon screening very early. Yes?
Let's say my dad has had prostate cancer, and obviously he's a man, so I know I can't get prostate cancer. And then my grandmother had lung cancer and actually died from lung cancer, but she was a smoker. Do either one of those have any increased incidence of anything, like any other types of cancer or whatever?
Great, very good question. Her question is, Dad had prostate cancer, Grandma had lung cancer, but she smoked. First of all, lung cancer smoking, yeah, that just doesn't count. But sometimes if there's prostate cancer in the family, plus uterine cancer, the body of the uterus, not the cervix, and some of these other endocrine cancers, stomach and all, are related. So all of a sudden, if somebody tells me, yeah, you know, my mother had breast cancer, but my grandfather had prostate cancer, and then my uncle had pancreatic, I'm going, you know, none of those are the same, but there are cancer syndromes that group together with various organs, and colon is also in there also. So when I see several cancers that were not environmentally induced, like smoking, and then there's a bunch of them, be sure and mention that to your doctor, because sometimes you'll find these families who do have these syndromes. Good question. Okay. All right, we're going to try. Excellent questions. So what is happening with all this screening? With us being able to screen, what has happened as far as cancer death rates? Look at this. For males, for females, for both sexes, they're going down. You know, because things were kind of creeping up, steady and creeping up. Then all of a sudden, we're really getting aggressive with screening, particularly in the 1990s, and cancer rates are coming down. Now, next door, they're going to be talking about cancer death rates in males. They're going to talk, look how lung cancer's plummeted. Why? Smoking has plummeted. You know, and look at prostate deaths from prostate cancer. You know, we got some good treatments going on here. All right? And the one thing that is, what else do we have? Colon and rectal, look at the deaths. Going down. Screening works. Screening works. All right? Now, interestingly, look at males, pancreatic cancer going up, liver and intrahepatic, the duct system of the liver, the bile ducts, look at this going up since 1990. Liver cancer is going up in guys, pancreatic cancer is creeping up, and also look in women, liver cancer is going up, and cancer of the uterus, the body of the uterus. Once again, not the cervix, that's coming down. It's going to go way down in another decade once these girls all get vaccinated, and normally they would have gotten cervical cancer in their 30s and 40s, and now they're not. But cancer of the uterus is going up. It's going up, and why? And we're seeing more cancer of the uterus, and it parallels obesity. Fat tissue makes estrogen. Estrogen stimulates the lining of the uterus, and if you do that for years and years and years and decades, that increases your risk of cancer of the uterus. Now, when we have periods, we also make progesterone. So that counteracts the estrogen. Birth control pills don't increase the risk of cancer of the uterus because they have progesterone in them. Actually, they plummet your risk. They lower your risk of cancer of the uterus because they have more progesterone than estrogen. It's just if we're just taking estrogen, that's the problem. Or with fat tissue, you've got too much estrogen on board when you're menopausal, that estrogen, but your ovaries aren't making progesterone. So we're seeing an increase in cancer of the uterus right here. But notice death rates from breast cancer are coming down and colorectal. But we've got this pancreas creeping up. So why are we seeing, and it's creeping up here a little bit in women also, but more so really in guys. And why is cancer of the pancreas going up? I don't know. I don't think it can be genetic, otherwise it would have always been there, unless there's some new mutation out there that people are having. Cancer, it makes you wonder, cancer of the pancreas, it's something that we're doing. Liver, we know. We know this increase in cancer of the liver that we're seeing here in women and in men is substance abuse. It's too much alcohol, it's drugs, drug poisonings, and with pancreas, we're not exactly for sure what it is, but all I can say is I'm pretty critical about what I put in my mouth and what I eat today. And I think it behooves all of us to look at eating healthier and just looking at what we're eating, the substances we're putting in our body today. Which I don't, if we look at more stress that we're under, you'd think it would affect all the cancers, not just pancreas. Not just pancreas. Good thought, though. Could it be stress? I think that it's something in our environment and all, and if we look at kind of what's happening with all of our processed food today and all the diet drinks and the kind of stuff that we're drinking today, I am happy to report that last year, for the first time, bottled water outsold soft drinks. Which that's probably a big improvement. And I used to be a Diet Coke junkie, all right? And I haven't had one in 10 years. I've just slowly weaned myself off of them, and the thought of even drinking one today makes me want to throw up. I've just gotten rid of any artificial sweeteners. And let me just cover that right now. I don't know that one artificial sweetener is safer than another. We have no data. We always think we have a safe one, then we find out it's not, then they come up with another one. So I just don't put any artificial sweeteners at all in my drinks. I drink tea without sweeteners, coffee without sweeteners, and water, right? But something to think about here, we are seeing this increase in pancreatic cancer. It behooves all of us to look at our environment, what we're putting in our bodies. And once again, it's nice to see this decrease in death rates from breast cancer. That is just incredible, because that's one thing I diagnose a lot of is breast cancer. Women come in for their annual breast exam, pelvic exams, and I've diagnosed so many breast cancers over the past 31 years at Scott & White. And I'm happy to report that the overwhelming majority of those women are alive and well. They are alive and well. In fact, it's, what's the most common cause of death in women with breast cancer? Heart disease and stroke. We cured your cancer, put you through hell, put you through surgery and chemotherapy, put you through hell, and then if we don't take care of ourselves, we end up dying from something that else that could have been prevented, that heart attack or stroke. And the majority of my patients with breast cancer are overweight. Not all of them. I just diagnosed one a couple of months ago. She was a runner, thin. Her risk factor was that she'd never had children. If you've never had children, or you're like me, you don't have your children until later on in life in your 30s, we are at higher risk for breast cancer. If you never have children or you have them later on in life. And she was in her 50s and had never had children, so that was her risk factor. But she's going to be cured with surgery. She's going to be cured. We picked it up early. Questions about that? About cancer?
Not a question, but just a personal testimony to that early detection and early action. My mother survived big three: breast cancer and colon cancer and lung cancer. And every time something came up, she went in immediately, and they're like, well, we'll watch this. She says, no, we're going to do something now.
So she's talking about being proactive about her health. Her mother's been diagnosed with 3 breast cancers. When something doesn't seem right, go get it checked out. Go get it checked out. And as women, we're more apt to do that. We are more apt to going, something doesn't feel right here. And I know as a physician, a lot of times what I do every time I'm in clinic is reassurance. Now that this pain you're having over here, I did the exam, here's the ultrasound, it's all normal, you don't have cancer. Because that's what we want to know, right? For women, if we have a pain, what is it? It's cancer, until proven otherwise. You know, with guys, they just friggin' ignore it, whatever. Unfortunately, a lot of guys do. They ignore these things. And even male physicians. Some stories I could tell you of male physicians, unbelievable. Not going in for care. Incredible. Okay, so some other common screening tests. A complete blood count. A CBC is what we call it, which is your red and white blood cells and your platelets. That's to test for if you're anemic, because if you're a young person having periods, the most common cause of anemia is you're having periods, and sometimes they're heavy every month. Yeah, but if you're older, not having periods, and your blood count is going down, we're like, why is your blood count going down? Are you having a little bleeding inside your stomach or your gut or somewhere that's so slow, and we need to figure out where you're losing blood and why? Because you have what we call a GI bleed, a gastrointestinal bleed, and you don't even know it. So we want to know what your blood count is, and if you're anemic, we need to figure out why. But if you're a young person, what is young? I don't know. Now that I'm 65, 80's young. Okay. I don't know. But young meaning reproductive age here. Okay. So we're going to get that, and we're going to check your platelets, make sure your platelet count's not low, that you don't have something like ITP, idiopathic thrombocytopenic purpura, where some reason your platelet count is going down, where your immune system is for some reason attacking your platelets. It can happen just for weird reasons. We don't know why. So getting a CBC occasionally is kind of cool. Or could your white blood cell count be really high? You have leukemia. So, and that's why when you're getting lab work done, a lot of people will throw in a CBC and just to check for some of these uncommon things. A complete metabolic profile, what we call a CMP. That's where we can check your electrolytes, your sodium, potassium, your carbon dioxide, your chloride, your liver function test, your SGOT, SGPT, all these liver function tests, your kidney function, what is your creatinine, what is your BUN, and those are tests of our kidney integrity, and our calcium and protein. With one blood test, this complete metabolic profile includes 20 tests. If you add up all the electrolytes, liver test, kidney test, calcium, protein, things like this, 20 tests within that one profile. And whether you're in the normal range is the 95% confidence intervals. In other words, they pick the values that 95% of normal people would be within these values. So you could be slightly off on one of these 20 tests, and it doesn't mean that's really anything to worry about. In fact, if you have it done and all 20 of them are normal, that's like almost freaky. So if you're a little off on one, don't be freaking out. Oh, your sodium's 2 points high, whoopee, okay? If it's way out of whack or it's trending up for some reason or whatever. So if you get this test done and all 20 are normal, that's pretty amazing. That's really cool. All right. And then thyroid function test. That's particularly important in women. Women are much more apt to have an autoimmune disease. Autoimmune diseases of the thyroid, like Hashimoto's, or all sorts of thyroid diseases, like lupus. Well, we are much more apt to have these autoimmune disorders than men for some reason. And it obviously has to do with the immune system and our hormones. And for thyroid function test, the screening guidelines on this really vary. But if your doctor's doing some lab tests, say, hey, would you mind throwing in a TSH, thyroid stimulating hormone? It's a simple TSH test, and if it's not in the normal range, they can do a whole thyroid panel on you. And obviously, if you have thyroid disease, they're going to be following it every year. But if your thyroid's normal and you don't have any change in your health, you haven't gained 50 pounds in the last year or something, there's no reason to repeat your thyroid except every many years, unless you have thyroid disease. Question?
I was just wondering why women have more of the autoimmune.
Oh, I think it is, a part of it is genetic, and I think part of it may be hormonal, our hormone system. The hormones affecting everything in our body, which do affect our hormones. It's really incredible. Women are just more apt to have these problems. Wow.
Question. If
Where?
my mother had thyroid cancer, is it beneficial to have this test done?
This test, very good question. Mom had thyroid cancer. Is it beneficial to have this test done? Very good question. This does not test for thyroid cancer. It tests for thyroid function. All right, thyroid cancer means you got a nodule in your thyroid. Most of those nodules, by the way, are benign. They're benign as can be. But they can do an ultrasound and decide, that nodule doesn't look good. And thyroid cancer is being diagnosed more because we have a tendency, if someone has a nodule, to do imaging and all. And it's very curable, very curable. One of my patients was just diagnosed last week with thyroid cancer, and she's going to be cured with surgery. Yeah. The good news is if you have to take out the thyroid, we know how to replace thyroid hormone. So that's good. And so if you do have low thyroid, it's one of the easier things to replace. Hashimoto's can be difficult to treat during that transition where you're trying to get things under control, but replacing thyroid in most people is not real difficult. Occasionally, some patients, there are difficulties, and I'm not a thyroid expert. Hashimoto's has been around, you've heard it in the last few years, it's been around for a long time, yeah. Okay, yes? Very good. Very, very good question. She's healthy, and her doctor said, you don't need that. You had it done years ago, but her husband, he's on it every year. Maybe because your husband had had some abnormalities, and they need to be followed every year. When you got abnormalities, all the screening stuff is out the door. You may have to be tested every few months if you're under therapy. I think that if you look, we're screening a lot of children. We are diagnosing children with adult onset diabetes. I mean, my husband operated on a 250-pound child the other day. 250 pounds. A child that was just like in high school, 250 pounds. We're doing bariatric surgeries on children now because of the high rate of obesity. So that's when screening starts early. We're seeing, a friend of mine is actually works in the Department of Cardiology, Dr. Catherine McNeil. In fact, she got her PhD in cholesterol abnormalities here from Texas A&M, and then went on and got her MD degree from Texas A&M. And she is, I call her, the cholesterol guru. And she says, I'm seeing children now with horrible cholesterol abnormalities and diabetes because of the crappy food that we're eating today. And so that's when we're starting to screen earlier. There are some pediatricians that say we should screen all kids now for cholesterol abnormalities, particularly if you have a family history of high cholesterol, you need to be screened early, and kids need to be screened early. And how often you should get it, if it's stone cold normal and you're still living healthy and haven't changed anything, I definitely don't think repeating it every year or two is necessary at all. I think it's overkill. I think it's overkill. My numbers are stone cold normal. I do not get them done every year. I got them done last year because our health plan made us get them done so we could get a $30 discount a month. I'm like, how stupid. So I had to go get it done. I knew they were going to be normal, so occasionally you have to for your insurance. Okay, let's talk about common women's health issues. So first of all, menstrual disorders, because I think there's a few reproductive age women in here, okay? Or how many of you in the room have adolescent daughters? Anybody? Yeah, we've got a few. All right. Applies to them all too. Well, menstrual disorders affect millions of American women and definitely do keep us gynecologists in business. They affect adolescents and all the way up to menopause. Pain with menses, what we call dysmenorrhea, heavy, irregular bleeding, menstrual migraine headaches. Menstrual migraine headaches, I learned from the neurologist, the brain doctors, are the worst headaches that reproductive age women get from adolescence on the way up to menopause. He goes, the worst headaches by far are those menstrual migraine headaches that occur a few days before and into the period. I mean, how many women in here have experienced menstrual migraine headaches? Yeah, they're common. They're common. And they are very common and they're very bad. And sometimes women end up in the emergency room with the pain. It's so bad. And what they are, in fact, all of these disorders, PMS, premenstrual syndrome, or PMDD, premenstrual dysphoric disorder. This is PMS with an attitude, all right? A bad one, okay? This is women who get depressed, very depressed before their periods. These are women who come into my office and say, please help me, I'm more apt to hurt my children during this time. They're out of control and they know it. All right, this is serious. Polycystic ovarian syndrome. Women who just have a lot of cysts on their ovaries, these women are also more apt to be overweight, not all of them, but a lot of them. They have more difficulty controlling their weight because of a metabolic problem. A metabolic problem. Right? And they're more apt to have problems with acne and increased hair growth. Right? Ovarian cyst, very common. Women don't realize every month when they ovulate, they're actually releasing an egg. Before that egg was released, their ovary actually formed a cyst. That's normal. It's when it gets real big and starts to cause pain that it's abnormal or it doesn't go away. But you develop a little ovarian cyst from where you ovulate every month if you're ovulating every month. And endometriosis causes horrible, painful periods. Endometriosis is where that lining that should be on the inside of the uterus, from which you bleed out every month if you're having periods, somehow that lining that should be on the inside of the uterus is now on the outside of the uterus, in your abdomen, on your ovaries, and fallopian tubes. And every month when you have a period and you're bleeding out the vagina, you're also actually bleeding inside your belly, inside your abdomen, and it's causing pain. So endometriosis is endometrium, the lining of the uterus, where it shouldn't be. And that causes painful periods. All right, so millions of women have one or more of these problems, and most of us have had one or more of them at least occasionally. You know, there are some women who, particularly athletic women, who have light periods, no cramps with their periods, and they've never had any of these problems. But I've also seen athletes who are just are flooding every month. Moms are bringing them in because they're missing the big game, or they're having horrible headaches, horrible headaches. All right. So, and today we're seeing more menstrual problems because this is the past, this is currently. In the past, women started having periods, their first period later, a late menarche. You know, they had early childbearing. Women started having babies earlier. They graduated from high school and started having babies. They graduated from high school, got married, had a bunch of kids. All right, many children, prolonged breastfeeding, and early death. Women were dying earlier. In fact, it was about 100 plus years ago, the average lifespan for women was 47. At the turn of, the 20th century, into the 1900s, it was about 47. So what was normal was to get married early, have a whole bunch of kids, breastfeed, and die. Menopause, what the heck's that? That was normal. And then with the advent of antibiotics and screening tests and cholesterol drugs and high blood pressure drugs and everything else that we've developed in modern medicine, being able to take out an appendix so people didn't die of appendicitis and cholecystitis and things like this. Now the lifespan for women is about 80. Absolutely amazing what happened in the last 100 plus years. But today, girls they're starting their periods earlier. They got excess body fat. Late childbearing. The teen pregnancy rate, by the way, is down over 60% in the United States. There used to be 550 births to teenagers every year when I started being involved in sex education back in 1995. I wrote the sex ed program for our local area, which expanded all over the state over the last 22 years, and it's one of the most commonly used sex ed programs. And more people got involved in getting kids sex education and making contraception accessible. That was also a biggie between those two. And so teen pregnancy rate came down, down, down. We used to have 550 births to teenagers in 1991. We're down to a little over 200,000. That is amazing. That is amazing. I still think it's too high, and I'm still working to get it lower, okay? But that's amazing. And more women, did you see they announced it a few months ago? Yeah, how women are delaying childbearing? Even more so than when I was having kids, all right, because I was kind of the rarity. I didn't get married till I was close to 30, and I couldn't find anybody to marry me. I mean, really. Okay, finally captured one. All right, and then had my 2 kids in my 30s. Is that natural? That's about as unnatural as you can get. But me and all my friends were doing it, okay, because we had our heads stuck in a book, okay? We weren't bar hopping, all right? So today, fewer children, late childbearing, shortened or absent breastfeeding. I had to get back to work. I breastfed 3 months. That was it. I'm done with this, all right? Increased longevity. Now we're having more periods. We went from about 150 periods in a lifetime to 450. I asked my mother, decades ago, I said, Mom, being a gynecologist, I said, Mom, you never talked about your periods. Did you ever have any problems with your periods? And understand, I'm the middle of 7. She breastfed, had a few miscarriages. She looked at me and she said, I don't remember having that many. I get it. Yeah. Okay. That makes sense. She did what is natural. What we're doing today is really unnatural. And what's it doing? We get to have all these problems. We get to have all these problems if we don't do something about it. Right? We get to have all these problems because incessant ovulation, having a period, ovulating month after month, year after year, decade after decade, is not natural. It's not biologically natural. But it's what a lot of women are doing. This leads to bleeding and anemia. The blood bank is like, Patsy, why don't you do something about this bleeding? Women want to come donate blood. They're anemic. We can't take their blood. Cramps, endometriosis, which leads to pain and infertility, ovarian cyst. The more times you ovulate in your life, you increase the risk of ovarian cancer. And that's why women who've had a whole bunch of kids breastfed or women who've been on birth control pills and weren't ovulating plummet their risk of ovarian cancer. It's been shown in every study that's ever looked at it. Long-term users of birth control pills plummet their risk of ovarian and uterine cancer. And you don't have these problems. So that's actually been my 25 years of research, and actually before I got into wellness was actually what I'm internationally known for and was speaking all over the world on. Because I realized years ago, but this is ridiculous. What we're doing is not biologically normal, so can we reduce the number of periods per year a woman has, reduce her number of lifetime periods for those of us women who don't want to have 10 kids and breastfeed, and can we reduce our risk of all of these problems? And the answer is unequivocally yes. And I came up with redesigning hormonal contraceptives to manage some of these menstrual disorders, because birth control pills are common. I mean, a bunch of you in this audience, I know, were put on birth control pills, not just for birth control, but for why? Heavy periods, cramps with your periods. But the problem was we invented the pills 21/7. 3 weeks on, estrogen plus progesterone, and a week off. Why? So you would have, we would mimic the average menstrual cycle. We'd create an artificial bleed. You'd think, oh, I'm not pregnant, and oh, it's socially acceptable. Oh, it's normal. I'm normal. I'm having a period every month. Made no sense to me. Having a period every month is not normal. Why would we force women to do something that's not normal? And we were the first research group in the world to document that women who take their birth control pills 3 weeks on, 1 week off, what I call the old-fashioned way, had more PMS, breast tenderness, bloating, swelling, pain during the week off than the real pills. Women stopped their pills for side effects. It wasn't the real pills, it was the week off causing the problems. We were duplicating what the natural menstrual cycle was doing. So I told these drug companies, you need to stop doing this. You need to, 7 days off is too long, or we need to give women more weeks of real pills so they'll have less periods, we'll have less problems, and all of a sudden we helped redesign. And the first pill that came out had 12 weeks of real pills in a row and a week off. We called it seasonal because you were having one period a season. So if your doctor ever recommended or recommends for your kids or nieces or whatever that, hey, you ought to take the pill where you don't have a period every month, you got a smart doctor. You've got someone who understands biologically what's going on. And that's my 25 years of research. I knew it would be effective in decreasing this problem. My 25 years of research was also, I had to prove it was safe. And people say, well, aren't you getting a big build-up there if you're not having a period every month? No. All birth control pills are progestin dominant. You don't get a build-up. There's nothing to bleed. There's nothing to bleed. And so, so anyway, and it lowers your risk of all of these problems. My patients with menstrual migraine headaches think I walk on water. And we published an article with the Department of Neurology. We're the first people to take women with horrible menstrual migraine headaches, put them on these continuous hormones, get rid of their migraine headaches. Get rid of them. And we were really one of the first people to publish that. Now, I'm not talking about those migraine headaches that occur at other times of the month. Let's clarify that, ladies. I'm not talking about those. I'm talking about the headaches you get just around the time of your period, right before and during. You know you're going to get them every month, and you know when you're going to get them. I'm talking about menstrual migraine headaches. Those headaches are not associated with, I'm losing my vision, this side of my body's weak. No. Those other migraine headaches that occur at other times of the month, sometimes those headaches are associated with what we call aura. If you get a bad migraine headache and you're thinking my vision is totally distorted, things are weird, or I'm losing part of my vision, or I'm getting weakness on one side of my body, you should not be on birth control pills. You should not be on birth control pills. That is a contraindication for those kind of headaches. Are you with me, ladies? Only menstrual migraine headaches, continuous birth control pills. All right? And some people can say, well, how long can you go without a period if you're on continuous birth control pills? Forever. Until you reach menopause, or until you develop a medical problem like high blood pressure or obesity where you shouldn't be on the pill. All right? Women who, particularly women over 35 who have risk factors for heart disease and stroke, they have high blood pressure, they have diabetes, they have obesity, you shouldn't be on birth control pills. Increased risk of blood clots in the leg. right? Increased risk of blood clots in the leg, and the pill can aggravate that. The only people that should be on birth control pills in their past the age of 35 are women who are healthy, non-smoking, normal blood pressure women. And a lot of those women are in my practice. They take continuous birth control pills. They have no periods. When they get close to menopause, we take them off of it. But if any point during that time when they're seeing me, that blood pressure is going up, you're not taking care of yourself, you put on another 20 pounds, you're off. You're off. Because you're putting yourself at increased risk for heart attack and stroke by developing those problems, and I don't want you blaming it on my pills, which could have aggravated it slightly. Now, the question is, if you're taking the real birth control pills, skipping the fake ones, and you're taking them week after week and month after month, do you ever develop bleeding? Chances are you probably will. You'll have what we call breakthrough bleeding. And we have the only prospective randomized control study in the world's literature on how to get rid of the breakthrough bleeding if you're taking your birth control pills continuously. Stop 3 days and restart. Stop 3 days, let your body wants to have a little period, let it have a period, and restart right where you left off. And that's our research. And I've been privileged to work at Scott and White through Texas A&M for us to do that research. It's been great. If any of you have any more questions about that, I'd be happy to answer. Oh, Brent.
Is there any link between taking the estrogen progesterone type pill with breast cancer?
Okay, you get the other T-shirt. Stealing my thunder, but you got it. Are there any risks to being on birth control pills? First of all, there's no more increased risk of being on it continuously versus 21/7. Risks are the same. The risks are the same. The chance of blood clots in the legs, things like that, which are rare, but they can happen, they're rare, are the same. It's not how many days in a row you're taking the real pills, it's the amount of dose of the hormones in the pill, and all birth control pills today are low dose. The question is, does being on birth control pills slightly increase your risk of breast cancer? And if it does, it's rare. It's a rare increase, because think about it. Breast cancer is associated with hormones, because women who've had their ovaries removed, go through menopause way early and don't take hormones, they lower their risk of breast cancer. But as I'll talk about later, they increase their risk of a lot of other problems, which are worse. But your breasts respond to estrogen and progesterone. So if you're not on birth control pills, taking them continuously, or 3 weeks on, 1 week off, that means your ovaries are making what? Estrogen plus progesterone, which your breasts are exposed to. That's why birth control pills don't skyrocket the risk of breast cancer. Your breasts are going, hormones are hormones, all right? And could there be a little bit of difference between the hormones and birth control pills and your natural as far as breast cancer is concerned? If there is, it's small. There's not a huge increased risk of breast cancer in women on the pill. Very good question. Or believe me, I wouldn't have been on them up until menopause. I'm like, have y'all noticed I'm into wellness? Have y'all noticed that? Yeah, I try not to do dangerous, unhealthy things to myself, and I apply that to my patients also. If I thought there was anything really bad about this, I wouldn't be doing it. In my research, I had to do 25 years of research to feel comfortable about it. Yes. Yes?
So I have a daughter that's 15 and she just started birth control because she has
Acne, yes. Your daughter has acne, birth control pills, yes.
Yeah, she started her periods when she was 12. She's 15 now. So the doctor wants her to take like 3 months with the 7-day
Yes.
free, and then go to the 3 months.
Yes.
Or,
He wants her to take 12 weeks in a row, not 3. Good.
yeah. Can I just tell her that she can take
Yes, she can skip those, or if she wants to have a period, don't take 7 days off, only take about 4 days off and restart early.
But for her whole life?
Don't you want her to have a baby?
No,
Not now.
Yeah.
She can keep doing it, yes.
Yeah.
I have my patients taking continuous birth control pills throughout their 40s. Some of them never have bleeding, they never have to take a break.
Then it's better to skip to the patches and rings.
There's no data with the patch. Excellent question. On the patch, it has an increased risk of blood clots compared to the pill, it looks like. I'm not a birth control patch fan. As I'll talk about, I'm a menopause patch fan, but not birth control. All right. Okay, we've got about 35 minutes or so. We're going to try to hit these last few. Perimenopause and menopause. Okay, has this been helpful?
Yeah.
All right, okay. Perimenopause is that time before menopause. Menopause is when you totally stop having periods because your ovaries have funked out. They're just quitting making estrogen. You're not ovulating. Perimenopause is when they can't decide what to do. All right, they're working sometimes, they're not working at other times. You have hot flashes sometimes, you don't other times. You have a period, then you go 2 months, 3 months, don't have a period, then you have another one, and you're like, what is going on? And it can start, for most women, it starts in the late 40s. For some women, it can start in their 30s, in their early 40s. Like a patient I saw yesterday. I mean, she's 42 and things are out of control. And she goes, what's going on? I go, you are perimenopause. She's just textbook. But it's happening early for her. And the thing about it is, what's happening is, rather than your hormones going up, they come down, come up, they come down. Your hormones may go up and stay up, finally come down, stay down, stay down, stay down. Totally erratic, totally erratic. And when you're having bad symptoms during that time, the only way you're going to halt them is to shut down the ovary. You got to shut down the ovary because it's your ovaries that are out of control. Women that are healthy, non-smoking, normal blood pressure women could be on continuous birth control pills. If the bleeding is the only problem, we can give you some progestin. And we don't have time to go into all of those. I give a 2 and 3 hour lecture just on how to manage the perimenopause. But the good news is that this is actually my expertise. I'm the perimenopause, menopause guru at our hospital. So these are the patients I get referred. And on how I manage those is really individual. It could be continuous birth control pills. It could be a Mirena IUD. It releases progesterone. We stop their bleeding. Our young doctors all love the Mirena. They have a baby, they want the Mirena IUD inserted. It makes their periods 90% lighter. And they don't have to take a birth control pill every day. And they're busy with these crazy hours, calls, and they're skipping their pills, and then they're pregnant again. Mm-hmm. All right? And so, in the Mirena IUD, millions of women have it. It is plummeting our need to do hysterectomy. It's safe. You don't have to take the hormones by mouth, so there's no side effects. You don't have to worry about blood clots in the legs or anything. And I never thought we would have an IUD that would be so amazing. I put in hundreds of them, never had a major problem with one. There are risks, but they're rare. I just have been fortunate. I picked the right patients, and I haven't had a patient have a problem yet. I keep putting them in. Maybe I will, but they're uncommon, although if you go to the internet, you might freak out if you get to the wrong website. But there's also, the point I want to make is that all these symptoms that are occurring, we can help you depending upon what is your problem. Are you complaining of the hot flashes? I can work with that. Are you complaining of this crazy irregular bleeding? I can work with that. How we manage it, we have a whole laundry list of things of how we can manage the perimenopause, but we have to know how it's affecting you. And we have to know what is your health status. What options do you have? Which is a good time to bring this point up. The healthier you are as you age, you get options. You get more options. There are a lot of patients in their 80s, they're having major surgery. They stayed healthy. They had options. Oh, you're 85? Yeah, we'll do the knee replacement. You're out there playing golf every day, you know? And it's the same thing when you hit the perimenopause. There's options, but sometimes you have something no fault of your own. You got lupus, no fault of your own. I can't put you on birth control pills, you know, in your late 40s. That would not be safe, you know? But sometimes it's stuff that we can prevent. We want to stay as healthy as we can because we want to have as many options as we can, as many options. So if you have any specific questions about perimenopause, I'll grab those later, because if you have something specific, maybe I can point you in the right direction. Okay. Now the menopause, as I mentioned, that's ovarian failure. Your ovaries are failing, all right? Decreased estrogen and decreased progesterone. You're not ovulating anymore. The eggs are gone. And we say you are in the menopause when you've had no bleeding for 1 year or greater. Now, you could be in your 20s and have no period for a year because you have PCO. That doesn't mean you're menopause. Your ovaries are still working. You're not having a period because your body ain't making progesterone. This is when your body's not making estrogen or progesterone. Are you with me on that? Some women are younger not having periods because they're just not ovulating. Their ovaries are still making estrogen, which is why sometimes we have to give them medications to help them ovulate so they can get pregnant. They're not in menopause. This is when you go for a period without for a full year because you have no estrogen or progesterone. So that's the kicker right there, okay? And it's associated with a lot of problems. Hot flashes and night sweats, which keep you awake. Vaginal dryness, which can lead to pain with intercourse. Joint pain, that's one of the common symptoms. Patients come in and go, I'm just feeling old. I'm feeling old. My joints are hurting. You know, and there is some physical decline that occurs there. Sarcopenia. Okay, what's sarcopenia? Decreased muscle mass, which occurred really before menopause. It starts before menopause. If we don't stay active, our muscles are turning to mush. Now, I have patients who are normal weight. They're actually overweight. Their muscles are gone. That's just, those little arms have nothing but fat in them. Even though on the BMI, the weight scale, they're normal, they're really not. They're what we call a skinny fat. And I have too many of my older patients that are skinny fat. Right? I want muscle on these bones, okay? Yes, I want to decrease my body fat. It's proven I can reduce my risk of 13 different cancers if I keep my body fat down. 13 scientifically proven, particularly breast cancer and uterine cancer, cancer of the uterus, all right? Emotional ability. I mean, I've been at the hospital, same hospital for 31 years. I've seen women, I've delivered their babies. 20, 25 years later, now they're having hot flashes. I've seen these women. I know them. They're teachers. They're friends of mine. They're level-headed. They hit the menopause, and it's like, what happened to Susie? She's been possessed. Yes, it doesn't happen often, but it can happen. Some women, you know, it's more apt to happen if you got stressors going on, teenagers are driving you crazy, relationship not going well, your work's not where you want it to be. You add on those things to this, and now we got a real problem. Or you add on a tendency to already have maybe some anxiety and depression. But sometimes I see it in people where I'm going, wait, this person was as clear-headed as could be, and now she is bawling in my office, and she tells me she does this every day. So occasionally it is the hormones, and my job is to figure out what's going on, okay? That's my job. We're also at increased risk for heart disease. Our cholesterol values can start to change. Osteoporosis, that estrogen goes down, our bones love estrogen. We have estrogen receptors all over our body, in our joints, in our bones, in our brain. And all of a sudden we go through menopause and it plummets and we wonder why things aren't the same. All right? Alzheimer's disease, urinary incontinence. A lot of these, I mean, these are age-related, but they're also to some extent hormonally related. And the question is, which is more of a contributing factor? And that's where all the research is. We know that with women, osteoporosis, bone mass just starts to go down. There's an accelerated decrease in bone mass when you go through the menopause. Those years around that time, there's an accelerated bone loss. And these other problems, heart disease, a lot of that's age-related. It's age-related. But women have heart attacks later on than guys, and a lot of it may be that protective effect of estrogen. Okay? But many of these problems are preventable or treatable with a healthy lifestyle and medical or surgical options. So we're not destined to have this. It's like my patients come in and say, well, you know, I'm just getting old. And I go, I'm not. Really? Come on. A lot of this we don't have to fall down this path. You know, we really don't. Now you might say, well, if all of this is associated with menopause, well, why don't we just all be on hormone therapy? Well, because there are risks and benefits to being on hormone therapy. But let's not confuse hormone therapy and menopausal women with birth control pills. Birth control pills are synthetic estrogen and progesterone. We have to give, yes, they're estrogen and progesterone, but they got a little, they modify them some because they got to be strong enough to shut the ovary down. You want to take birth control pills because you want to shut the ovary down so you won't ovulate, you won't get pregnant, you won't have PMS, you won't have menstrual migraine headaches, you won't have cramps and all those other problems. You won't have ovarian cyst. You're going to have to shut the ovary down. When you're menopause, do you have to shut the ovary down? No, it's already shut down. It's already shut down. All you want to do, as far as I'm concerned, if you're going to be on hormone therapy, is you want to give a little bit just to take care of the problems, if you have any of them. And it's natural estrogen. It's not synthetic. Even the FDA-approved products are natural. 17-beta estradiol is the estrogen that your ovaries were making. Guess what? That's 17-beta estradiol that's in the estrogen tablets, that's in the estrogen patch for menopausal women, that's in the estrogen, in the ring. These are natural estrogen. And you can get natural progesterone, micronized progesterone. All right? And these are FDA-approved products, and they're natural, and they're low dose. So don't confuse birth control pills with menopause hormone therapy, which is natural. Okay? Now, what are the FDA-approved indications to being on hormone therapy? Why should some women consider it when they're going through the change? It's FDA-approved for prevention of osteoporosis. FDA-approved. If you're without estrogen, you are at much more higher risk to get osteoporosis, thinning of the hips, the spine, collapsed vertebra, break your hip. And just about as many women die of hip fractures in this country as breast cancer. In fact, you can die faster. Maintaining our bone mineral density is important, ladies. It's very important to me, which is why I want to talk about this now. We need a bone density. When do you need a bone density? A bone density is the easiest test you will ever have done. You lie there, they x-ray your spine and your hip. It takes a few seconds. You don't even have to take your clothes off. All right? It's a simple test. And when should you have it done? If you have a family, everyone, they say, should have it done by 65. But if a lot of women wait till 65, they're already going to develop osteoporosis. We want to pick up what? Bone thinning, which is called osteopenia. You're having a little thinning. And then if you have thinning, the question is, are you going to develop osteoporosis? A lot of my patients, they're going through the menopause. They can't decide whether to be on hormone therapy. They're having a few hot flashes or whatever. And I go, your mother had osteoporosis? Yeah. And I go, yeah. And I go, well, let's get a bone density. Let's just check your bones out. Particularly some of my patients, they're thin Caucasians. I go, you're at increased risk. Blacks have great bones. They have great skin. They just get high blood pressure, okay? Whites, horrible bones, horrible bones. And so a lot of it is going to be a race issue. Just like blacks should probably have colon cancer screening earlier, much more common in blacks. And your doctors ought to be looking at that. So a lot of the tests we order is going to be depending a lot of it on our race. It could be on our race, our family history. Those are the things we have to look at it in some, all right? We have to look at. So, but with bone density, who's really at risk, higher risk, are Caucasians and Asians more so than black women. So, and this happened just a couple of months ago. I had a patient, she couldn't decide, and I said, you know what, I'm concerned about your bones. Do you mind if we get a bone density? She goes, no, she's in her early 50s. We got her bone density back. She didn't have osteoporosis, but she's about one step away. And here she is, 53, going through menopause. What's her bone density going to be in 2 years? Osteoporosis. So with her family history and her body habitist, I said, we need to get this now. She said, I'll take the hormone therapy because I don't want to get osteoporosis, plus she's having hot flashes and night sweats. She's going to kill two birds with one stone, and we're also going to prevent the vaginal thinning and the dryness, which she doesn't want to happen. These are the 3 FDA-approved indications to be on hormone therapy. FDA-approved, low-dose products. I am not anti-estrogen. I am an estrogen minimalist. I'm in just being on just enough to keep you out of trouble, to protect your bones, get rid of 75% of the hot flashes. If you try to get rid of 100%, you're going to be chasing high doses in most women. My goal in my patients is I tell them, I want to get rid of about 75% of those. I want to get you back to sleep. Occasionally you may get that night sweat, but I don't want to be putting you on high-dose therapy. I'm going to stay. If you're going to be on hormone therapy, it's going to be low dose, it's going to be natural, it's going to be FDA approved. Now, there are other possible benefits, but not FDA approved. Prevention of heart disease. In the Women's Health Initiative, those women who started hormone therapy at a young age had almost a statistically significant decrease in heart disease. It didn't quite make statistical significance because that was also the smallest group. They didn't have enough women in that group. But the FDA even told the company, you can put that in your package insert. And they're very critical about what can go in there. Normally it's just risk. And they go, no, you can put that in there. Put that in there. We think that the people should know that. But it's not FDA approved for that. And also just emotional well-being. If you're sleeping better, you're just going to feel better the next day. Quality of life is important. But estrogen is not an antidepressant. It's not approved for depression. It's not approved for anxiety. Do I have it help some of my patients? Yes, but it's not FDA approved for those reasons. And with the estrogen patch, in one study compared to the pill, there was an improvement in libido. Improvement in libido. Some of my patients are interested in that. All right? And so the patch, but that was one study, but it was a good study. It was randomized. No one knew who had the real patch versus the fake patch versus the real tablet versus the fake tablet, because they were both on both, but no one knew which ones were real. So it was a really good study. Not even the doctors who followed them knew until they broke the code. And they broke the code and they looked at all their surveys, their questions, and found that out. So that's what you call the best study. When nobody knows who's on what, until the end when someone who's monitoring the data breaks the code. It's what they call double-blind randomized. In other words, you don't get to pick. We pick the number. Randomized placebo, some people are getting faked up in its control study. So these are some of the benefits to being on hormone therapy. Now, what are the risks? What are the risks? There is a rare increased risk of breast cancer if you're on it for several years. And most of the data says at least 3 to 5 years. And it's a rare increased risk, and we only know that with one product. We don't have data like for the natural estrogen and progestin. The product that was used was actually a product that has estrogen from pregnant horse's urine, Perimenopause, and a synthetic progestin. And there is some evidence that being on the natural progestin, there's some evidence that could be a lower risk, but we don't have really good data on that. So I tell all of my patients, I got you on low dose, I got you on natural. I'm not going to be like a lot of people out there promoting products saying, oh, there's no increased risk. I'm going to tell you there could be a rare increased risk. All right? And every woman has to decide. They have to look at the risk versus benefits. Now, if you're on oral estrogen, there is an increased risk of blood clots in your legs that could go to your legs if you're on oral estrogen. But my patients that are really physically active, they're walking every day, and they're not obese, they're fine. Their risk is really much lower. But I don't like my overweight patients on oral estrogen. I want them on the patch. In fact, I want most of my patients that are going to be on this menopausal low-dose natural therapy, I would like them on the patch. Now, there's a rare increase of stroke and heart attack with the oral estrogen if it's begun 10 years into the menopause. In the Women's Health Initiative, we discovered the women who started hormone therapy within 10 years of their last menstrual period, we weren't seeing the heart attacks and strokes. It was in those women who were older who shouldn't be on it. Because as we age, particularly if we're not taking care of ourselves, the plaques start to form. In our coronary arteries on our heart, in our carotid arteries in our neck, Then if you take oral estrogen, it increases your clotting factors from your liver, and that can be bad. If you use the patch, which you put on your abdomen or on your buttocks, it bypasses the liver. So we don't know about starting the patch maybe after 10 years. But the thing about it is, if you want to prevent osteoporosis and a lot of these problems, if you're going to start hormone therapy, the best time to do it is right when you're going through the change or within a few years after. The data is very clear on that. And that's what this says. Hormone therapy is ideally begun within a few years of the last menstrual period. Or if you had a hysterectomy and your ovaries removed, right then and there. Okay? Now, what are some of the non-hormone ways to manage menopause problems? Management of hot flashes and night sweats. There are some herbal products. Soy, black cohosh. There's a product called Estroven. Sounds like estrogen. It's an herbal product, and it helps some people. Actually, it's been shown some of the low-dose antidepressants are quite effective in reducing hot flashes. Drugs such as Paxil, Effexor. And in studies where women were put on it for depression, they go, well, my hot flashes are better. So they did the randomized trials, and sure enough, they do help some women. These therapies, gabapentin, which is used for pain, is really good at helping hot flashes. And these therapies are really important in my patients who have breast cancer and other problems, and I can't use estrogen. I'm looking for these other modalities to try to help these patients. What about osteoporosis? If you have osteoporosis, you really have to look at your calcium and vitamin D. With normal bone density, there's really no reason to take calcium. In fact, too much calcium can cause calcium on your arteries, which is not good. The best way to get calcium is in your diet, and that's why I drink the almond milk that says 50% more calcium than dairy. Some brands don't, but most of the brands say that. I like to get my calcium in my food. I do not take calcium supplements, even though I have a little thinning in my bones. I don't have osteoporosis for one reason and one reason only. I'm on low dose, the ultra low dose estrogen patch. I would have osteoporosis like my mother. There's no doubt about it. You cannot prevent it just with exercise. All right? But everybody has to decide. I had to decide what I was at increased risk for, osteoporosis. Plus, not to mention I'm sleeping better. Now, and there are also numerous FDA-approved medications for osteoporosis that are not hormones. And I don't have time to go into that, and I'm not an endocrinologist. Some of them you take once a day. Some of them you take once a week. Some of them you take once a month. Some of them you take a shot once a year. So if you have osteoporosis, there are a lot of therapies out there. And we cannot negate this muscle building. I heard an amazing lecture at the National Menopause Society meeting a couple of years ago. This guy was incredible. He was a bone expert, and he dealt with osteoporosis, and he just blasted this audience of hundreds of healthcare professionals. He said, all you guys want to do is pass out drugs. He goes, how many of y'all get your patient in a muscle building program? And very few people raise their hand. He goes, you need to build muscles around thin bones, and even non-thin bones, obviously. And it's something that we forget to tell people. As we age, our bones are going to thin, if we don't do something. But one thing that we can do is keep up our muscle mass around that. All right. Some other things, management, because I'm going to try to. I've got 10 more minutes, or 10 or 15 more minutes, and like I say, I'll stay late for questions. Management of the joint pain, the physical decline, the sarcopenia. There are herbal products. Have any of y'all, turmeric, have y'all heard of that? Yeah, it's herbal. And the product, and I don't like to promote specific brands. Plenty of companies want me to promote their products, and I don't do that. All right, and this company is not promoting my product. I put the name up there because this is the product that the studies used, called Curamed. And I looked at the data because a few of my patients with arthritis swear by it. And I've had patients try it, and 2 months later, they're emailing me going, this has been awesome. So it would take a couple of months, and you can get it on Amazon or at a health food store or something, but Curamed is supposed to be the best brand for absorption. But you would have to take it a couple of months before you noticed a difference. glucosamine and chondroitin for the joints. There's some data on that. If you have bad joint problems, the data's not really good, but there is some data. Yoga. We should all be doing yoga. All right? This has been a game changer for me. I had leg pain. I had joint pain so bad, shoulder pain, I couldn't even sleep. And I went, I don't want injections, steroid injections. I don't want surgery. I took up yoga. Gone. Now, I don't know that you would have the result I would have, but my leg pain I used to have from sitting for a long time, traveling in a car, this can really help a lot if we get into a very good yoga class. And yoga is not yoga is not yoga. You got to find what works for you. Weight-bearing exercise, I do this 2 to 3 times a week, at least. I want to maintain my muscles as I age. What about urinary incontinence? Kegels! This is crazy. You know, I do this for a living, really? Here I am, I'm lifting weights, I'm taking care of myself, okay. So I'm getting in my 50s and I'm noticing my bladder control is not what it used to be because I wasn't doing my pelvic exercises. I was lifting weights and I forgot to exercise my pelvic muscles. So I went to 2 sessions with our pelvic floor physical therapist. They specialize in the pelvic floor muscles. And I went, I'm signing up as a patient. Went for 2 sessions. I did what they said. I do the exercises several times a week. Loss of urine, gone. Gone. It is first-line therapy for loss of urine in women now. Because as we age, those muscles weak, especially if we've had babies vaginally, things stretch out. As we age, have you noticed everything wants to sag? Everything? Yes. And you can go to YouTube and Google and Kegel's exercises and follow the instructions there. But if you're having a big problem, get your doctor to refer you for pelvic floor physical therapy. There's too many women out there using Depends and other stuff, and that's first-line therapy. Now, you still may need surgery, or you may need medications. If that bladder's dropped way down, you can Kegel till the cows come home, and it ain't gonna work, okay? You can tell I'm from the farm and the ranch, okay? Born and raised Texan, all right? And those cows take a while to come home sometimes, anyway. But if it's falling way down, I go, no, can I do Kegels with that help? And I'm looking at this lady's bladder, it's fallen all the way down. I don't think so. We need to tack that baby back up. All right, blame it on that 9-pounder you had, okay? All right, so there's all options. The point I'm trying to make is we want to nip this in the bud when we're young. We don't want to be in a nursing home wearing diapers. We want to try to nip this in the bud. There are good therapies. Find a good doctor. And at Scott and White, we just happen to have the best. I love showing pictures of Ernestine Shepard. She's in her 80s now. Go to YouTube and Google Ernestine Shepard. She's in her 80s motivating women. Get off the couch, girls. Let's move. Because in her 50s, she was a couch potato. Her and her sister, and they decided to become bodybuilders. She is the poster child for prevention of sarcopenia, okay? And I love this, you know, this one right here, the 100-yard dash. I don't think it's going to show here, but I don't have time to show it anyway. This lady's 91, she's 82, she's 92. Look at these ladies going. This needs to be us, ladies. Okay? This can be us. No? She's 82 years old. Look at those slow pokes coming up the rear.
They got cold and sore.
Look, 92. Oh, here comes Hurricane Hawkins in black. 101. Man, that's the way I want to be. We can do this. Remember, first and foremost, this is what we need to be doing, living healthy. Okay? And this is the study. You want to prevent Alzheimer's? Anybody in here want to prevent Alzheimer's? The study right here, a 44-year study. I call that a long-term study. They followed these women for 44 years. Those with the highest level of fitness had an 88% reduction in dementia. I'm not talking 20% reduction, 30%, 50, 88%. Even those with the horrible family history who had the allele, the genetic allele, delayed it by over 10 years. Incredible, incredible. Physical activity, us eating healthy, that is first and foremost over anything. What about supplements? I don't have time to talk a lot about it, but let me just tell you this. There's no supplement out there that's recommended for everybody, not even a multiple vitamin. In fact, in one study of menopausal women, they followed thousands of women. Those that took a multiple vitamin and those that didn't and on, they followed them for like 12, 15 years. The women who didn't take the vitamins lived longer. This was published in JAMA. The recommendation was, we don't know that this is necessary. The main thing is eating healthy. If you're getting in a lot of vegetables and fruits and nuts and things like this, you're getting your stuff in. And if you want to take something like that, don't go take one of these synthetic vitamins. Go get you some Supergrass. Okay, there's a product called Amazing Grass. You just get a scoop of it. It's the ground up vegetables and nuts and fruits. Get a scoop of that and mix it with water or a little bit of juice and gun that. Do some natural stuff. But as far as having to take all of these supplements and all, now that, remember, that's for people, for general guidelines. If you are iron deficient, you need to be taking iron. If you're B12 deficient, you need to be taking B12. Right? If you have a deficiency that your doctor has diagnosed, that's a different story. You need to be taking that. But just something that for me to tell y'all, ladies, we should all be taking this, I can't name one. I can't name one. And if you're having hair loss, try some biotin. It may help, and some things like that if you've got a specific problem. But this is a lecture in and of itself, of which there is some good data on particular disorders, that we really should consider if you have a particular disorder. We just don't have time to go into that. But remember the World Health Organization definition of wellness. Let's be concerned not only about our physical and our emotional health, but our social health, the quality of our relationships. Because you can look like $1 million, but if your relationships aren't good, life's just not good. Our financial well-being, what are we spending our money on? A lot of times we're spending money on stuff we just don't need. And our spiritual health, which is really the framework of our health. What is guiding us? No matter what your faith is, spiritually, what's guiding you? Because if spiritually you're not being guided, then that means you're listening to our culture, which could be causing some problems, all right? And remember, we're going to do that because we want to meet our role expectations. And remember, what's a common cause of death not listed on death certificates? Medical errors. In fact, Johns Hopkins released an article saying it's the 3rd most common cause of death in America. I find that embarrassing as a healthcare professional. Very embarrassing. I can tell you we're trying to straighten up our act. But sometimes we don't order the right test. Or we didn't act on the test. We didn't recommend that you have this test done. Or we didn't do what we should have done. Or we gave you the wrong medicine. Or we could have given you something. And stay as healthy as you can. And when you develop a problem, go to reputable sites. Mayo Clinic, NIH, CDC. Go for reputable information. Understand your health problems. And partner with your provider. Partner with your provider. Don't just turn your health care over to your provider. That's not a good thing to do. Okay? And remember, we want to stop this. Death rates increased for 8 out of the top 10 causes. In fact, life expectancy in the United States decreased again in 2016 and 2017. And a 3-year trend in decreasing life expectancy has not happened since the flu epidemic 100 years ago. We have all this fancy stuff in medicine, but unless we really look at our lives and live healthy, we're negating all of that. Because death rates in the United States are going up, but they're going down in France, Germany, United Kingdom, Australia, Sweden. We're buying into too much bad stuff here in America, okay? Deaths from poisoning, suicide, chronic liver disease are going up. And it's not just in middle-aged people, we're seeing it in younger people also. So we want to not be of that. 11 essential elements to health and happiness. We want to live by those first and foremost, okay? And by the way, if any of you don't have the book, the workbook, and the journal or whatever, do most of y'all have it? Yeah, if you don't, we've got a few copies here like that we're selling at cost, only to A&M, okay, if you need them. And remember, on my website, the Partner with Your Provider worksheet, just go to livingwellaware.com, click on Publications. It's got the normal numbers, and you plug in your numbers, okay? And sign up for, how many people signed up for my newsletter? Yes, okay? Just sign up at the bottom of the home page, or just text 22828 and enter capital LWA, okay? It's my free blog. How many of y'all are reading it? You like it? Yeah, cool, cool. All right, Living Well Aware at Texas A&M, this has been fantastic. Y'all are participating, it's been great. We've done wellness conferences, newsletters, the journal and the planner have been available, and I'm happy to say I'm going to be back October the 4th at the General Services Complex talking about, whoops, misspelled, that should be Rituals Rule, Secrets of the Successful. I'm going to go over the data on why certain people are physically successful, emotionally successful, financially successful, why some people are more successful in their marriages. We're going to go over secrets of the successful and how, if we all get into these healthy rituals. And I'm going to share some of the things I've started doing, I and my husband have started doing, that have been total game changers. I'm going to share my morning ritual and my evening ritual, okay? And I'm going to go over the data of a lot of these people. And lunch is going to be provided by Living Well Aware. It's going to be healthy, okay? It's going to be good. And I'm happy that I've been all over the A&M campus speaking, and it's been a joy. I know I don't have all the locations that I've spoken, but a lot of them, and I've really appreciated the opportunities to come speak to your employees there. And I welcome opportunities to come speak on whatever topic y'all want. That's been a lot of fun. And a thank you to Courtney. Was Courtney back there? And Mary, give them a hand. This topic was their idea, not mine. Okay, so thank them. They've been picking the topics. If you've got other ones, let them know. Remember the goal of Living Well Aware. Let's live healthy, live happy, live holy, so that we can lift humanity. Thank y'all very much. Thank you. Thank you.